And our last speaker is Katrin Mehler. You are also from Germany, but you're working in another place. So where in Germany do you?
In Cologne.
Is that and where is Cologne?
It's a city
in
west, and Thomas is Berlin in the east.
Oh, I see. Yes, and you're most welcome, and you're going to tell us all about the scientific behind it.
Yes, which is really hard to do after Thomas' great pictures and videos. But I try my best not to bore you to death.
But you are not only a neonatologist, you are also a pediatric intensive care. You've been working there, and also in pediatric infectious diseases.
Yeah.
Fantastic. Welcome.
Well, thank you very much for this invitation to Stockholm. A whole day on early bonding. Congrats. That's a fantastic event. I hope you don't mind that I changed my title a bit and will use the term delivery room skin-to-skin contact, or Drscc, throughout my talk. To cut a long story short, the idea behind delivery room SSC is to facilitate secure attachment and to promote sensitive parenting. And this said, we could jump right for the next coffee break, but I guess there might be some questions you'd like me to address. First, why would we want that? Facilitate secure attachment? And do preterm infants have an issue with attachment? And if they do, does it matter? And to answer these questions, I have to take you back to the 1970s and into attachment theory. Mary Ainsworth introduced 3 different patterns of mother-child attachment: a secure one, and 2, or better said 3, insecure ones. The fourth, this insecure, disorganized attachment pattern, was added later. So what we have is 1 secure, organized attachment pattern, 2 insecure but also organized attachment patterns, and 1 disorganized, insecure attachment style. And to answer if preterm infants have an issue with this, we have to talk about disorganization and insecurity separately. Attachment disorganization in preterm infants is a problem because it's associated with psychopathology, with emotion regulation, with social skills competence, and it's associated with brain injury and immaturity. And here you see an ultrasound scan of a 23-weeker with severe ICAVH. So the risk is highest in extremely immature infants, and disorganized attachment is more frequent in small infants compared to full-term infants. It's around double. That's from a study from Volke published in 2014. Attachment insecure in preterm infants is a different matter. Attachment security is a good thing because it's associated with emotion regulation and social skills competence, and it's associated with parenting style, there where we have a potential target to intervene. And to give you a rough number, around 3 in 4 low-risk full-term infants have a secure attachment, so that's the normal range. Attachment insecurity may be targeted by interventions focusing on sensitive parenting. It's still a bit unresolved if prematurity itself increases the risk of insecure attachment. There are 2 studies hinting at that. A study from Volke, reporting a number of around 61% secure attachment in small infants, and a meta-analysis from Koya, where the pooled proportion of secure attachment in preterm infant was 64%. You can see that's not much lower than the average low-risk full-term infant rate. But it depends on the rate of immaturity, and it depends on the age of assessment. So an Italian study comparing attachment described a significant higher risk of less optimal attachment at school age for the preterm sample. So again, are preterm infants at a higher risk of insecure attachment? And the answer is yes, if attachment is assessed later at school age, not at toddler age. And yes, if very immature infants are included. And 2 studies support that. Pinkert observed a decrease in secure attachment from over 50% at 12 months of age to 25% at 7 years. And in adolescents born with a birth weight below 1,500 grams, only 1 of 3 children was securely attached. So in low-risk samples, the pattern of attachment stays constant from infancy to early school age. But that doesn't seem true for high-risk samples, and that means preterm infants. They lose attachment security if lifespans over 5 years are assessed. Maybe with all this talk on attachment security, you're wondering how it actually can be assessed, and that depends on age. In most studies on attachment in preterm infants, attachment is assessed with the strange situation procedure invented by Mary Ainsworth. It's the so-called separation reunion test. You can see the setting here. It can be used from toddler age up to 4 years. The child is observed playing for 20 minutes while caregivers and strangers enter and leave the room in a strict course, and the situation varies in stressfulness, and the child's responses are observed. The amount of exploration, how is it playing with the new toys, the child's reaction to the departure of the caregiver, the mother leaves the room at one point, and of course the child's reunion behavior with the caregiver. Later on, other tests need to be done to assess attachment, and one of those is the so-called attachment story completion task that can be used from early school age. And the investigator in this test provides the child with the beginning of 5 different stories by playing them with a family of dolls, just as you can see here. The stories are set up to induce attachment behavior. For example, the child in the story gets separated from the parents or spills juice, or my favorite one is afraid of monsters under the bed. And the child continues to play this story. And the child's reaction to the situation are supposed to reflect his or her attachment pattern. And we recently published a study on attachment in preterm infants, and we assessed attachment in 6 to 8 years old children with the attachment story completion task. You remember the family of dolls and the monsters under the bed and all that? So we did that test, and we included 3 groups of infants, very preterm infants, moderate or late preterm infants, and we had a control group of full-term infants. And as you can see, the results were quite horrible, because only 19% of very preterm infants had secure attachment at this age, and the moderate late preterm infants did a bit better, but 40% is still not a very high number. And these are the baseline characteristics of the preterm groups in our study. There are naturally big differences between the groups regarding NICU days, birth weight, gestational age. There were no differences in breastfeeding and early skin-to-skin contact. And this slide shows the attachment security score. The higher the score, you can see it here, the more secure the attachment is. And I show it to you because it nicely illustrates that there's a kind of trajectory linking immaturity and attachment insecurity. Very preterm infants have the lowest, and full-term infants, oh, sorry, can I go back? Here. Full-term infants, the highest scores, these are the lowest, and the moderate late preterm infants are somewhere in the middle. So why do we want to provide Drscc? Why can't we just provide SSC as intermittent kangaroo mother care at the NICU, as we've practiced for so many years? Why all the fuss in the DR? It's interfering with our routines. We have to convince all the people there, the obstetricians, the anesthesiologists, the midwives. Well, secure attachment in preterm infants reduces the risk of behavioral problems, ADHD, and impaired neurodevelopment, and thus has an impact on our outcome, and that's why it is important. And that's what Thomas already was talking about, oxytocin, and the 2 elderly pediatricians from the United States, Klaus and Cannell, who termed this the first golden hours and the sensitive period, where oxytocin peaks directly after delivery and helps to facilitate sensitive parenting. And that's why this time, in my eyes, is very important, and to use the first hours after birth for the SSC. Oxytocin increases maternal sensitive behavior and thus increases the chance of secure attachment. And in animal studies, inhibition of oxytocin leads to less sensitive parenting. And here is from a study on salivary oxytocin in mothers and fathers, and you see the increase during SSC compared to pre-SSC levels. The concept of this sensitive period has found its way into evidence. In 2009, Ksenia Bystrova published a study on healthy term infants who were randomized after birth to be either separated from their mothers for 2 hours or to stay with them. And she analyzed mother-child interaction 1 year later and observed that those infants who had been separated behaved more irritable and dysregulated, and the mother-child interaction was less optimal. And we did a similar study with preterm infants and compared attachment patterns of mothers who had been able to see their infants after birth, just seeing, no SSC. And that was not a randomized study, but a post hoc analysis. But the results really surprised us, because simply seeing their preterm infant for a couple of minutes directly after birth increased the chance of secure attachment by an odds ratio of 4.5. And this led to the idea and the design of the DAISY study. We thought, if seeing had such a dramatic effect on attachment, what more could SSC do? And so we planned to compare the effect of delivery room SSC for 60 minutes compared to visual contact on mother-child interaction at 6 months corrected age, at reactivity of HPA axis, maternal depression, bonding and breastfeeding, and expression of several key molecules involved in stress regulation. And you're interested in all the details, you can find them in ACTA. We published it in 2020. And these pictures may give you a more concrete idea how we practice Drscc. On the left, you see 2 infants who were randomized in the 60 minutes Drscc group. They are on CPAP via a pharyngeal tube. A gastric tube was inserted to prevent gastric distension. We use very high CPAP levels. And a peripheral line is in place, just as you saw on the video Thomas was showing you. Monitoring is only done by pulse oximetry. Consequently, oxygen saturation and heart rate are shown on screen. And to prevent hypothermia, we learned that we don't have to fear it, but we feared it anyway. The infants are placed under a transparent wrap and covered with pre-warmed sheets. And on the right side, you see the setting for the visual contact group. The visual contact infants visited their mothers for 5 minutes after initial stabilization. And this is a flowchart of our study. We screened almost 300 preterm infants born between 25 to 32 weeks of gestation. Multiples were excluded, and we did not include infants who needed primary resuscitation or mothers who had complication during or after delivery. Finally, 88 infants were randomized. We lost some until the mother-child interaction video was scheduled at the corrected age of 6 months. This is our what we call safety data. There was no difference between the groups regarding gestational age, birth weight, or gender, so randomization worked nicely. And there were no difference upon NICU arrival regarding FeO2 or CPAP level. Here I marked the skin temperature because the SSC children were warmer when arriving at the ward. That was a big discussion before we started the study. And there is some data on the neonatal course is shown. No differences there. More SSC infants were later discharged exclusively on breast milk. And there were no significant differences in the short-term complications of prematurity, such as IVH, BPD, FIP, or NEC. So we were quite happy with that. And we assessed depressive symptoms on day 3 at discharge and 6 months corrected age, and found that compared to the visual contact group, the SSC mothers had a significantly lower risk for depression, 45 versus 15%, but this was lost at discharge. This difference was lost at discharge and after 6 months of age. And we found differences in the PBQ, that's a parental bonding questionnaire score that showed a higher risk for impaired bonding for the visual contact group. So, and this is our primary outcome. It was mother-child interaction at 6 months corrected age. We videotaped a nappy changing session and assessed motoric, mimic, and vocal responses of both mothers and infants. And here we found that SSC mother-infant pairs interacted more, and this higher amount of interaction was predominantly caused by maternal and infant motoric response. And I can't go into detail on the epigenetic data, but this is the citation if you're interested. And this is another figure from our study on attachment at 6 to 8 years. And on this figure, the very preterm infant group is divided into 2 groups: those who had visual contact in the delivery room and those who had skin-to-skin contact. We did not observe differences in the attachment security scores, but of course the numbers were low. But we found a significant difference in the attachment security score between low-risk full-term and very preterm visual contact infants that was lost when we compared them to the skin-to-skin infants. So we speculated that the early SSC may promote maternal sensitivity and help to influence attachment later. And this slide is supposed to give you an impression how we practice Drscc in Cologne. Drscc started approximately 45 minutes after delivery. The majority of small infants is delivered by C-section, and it takes about 30 to 45 minutes until the surgery is completed and the mother can be transported to the recovery room. I got here my papers confused, sorry. On the infant side, we immediately start with CPAP after birth. After 10 minutes, we should see a stable breathing pattern. We insert a gastric tube to prevent stomach distension and a peripheral IV line, and we give fluids, caffeine, and antibiotics depending on the cause for delivery. And after 30 minutes, surfactant is applied with the LISA procedure. And most infants after that need some time to recover from the strain of laryngoscopy. But after 40 to 45 minutes, both mother and infant should be ready for SSC. And of note, the peridural anesthesia should still keep the mother free of pain. And I want to finish my talk and introduce you to Ada. She was just born last week, so I'm really happy to bring some new photos here. And she was born with 24 weeks of gestation with a birth weight of just over 500 grams. The cause of delivery was PPROM and signs of chorioamnionitis. She was delivered by C-section, and she is on CPAP via pharyngeal tube. She received surfactant. I think you can still see some bubbles from the surfactant here. And she started SSC at 45 minutes of life. So, tack så mycket, and I'm looking forward to your questions.
Thank you very much, Katrina. Wonderful to hear your experience and scary results, really, in the long-term follow-up.
Yeah.
With yeah. So, any questions to Katrina? Yeah.
Indeed, very scary and very illustrative and worrisome. Is there salvation for these babies? Because when I listen to your story, I tend to think maybe it's a brain structural thing that happened, and if we replace the amount of attachment to the amount of trauma if you look at the babies that way, that the babies who were born earlier suffered more trauma in any way, either not being with the mother or being harassed by doctors. And so the chance of trauma is much higher when you're born earlier, and which might coincide with also the amount of bonding you can create. So I'm very intrigued, and thank you for this talk, but yeah, I don't know if you know if the big salvation, if you have an answer, because it's really scary actually.
I mean, it will be hard to get into disorganized attachment, because that's really brain injury that causes it, and that will be, I mean, you have to prevent IVH to prevent that and to prevent PBL. But attachment insecurity, I think we can address that. And I think it's not only, the solution is not only delivery room SSC, because it's what you're all doing here, SSC over a long time, continuous SSC. It's not that 1 hour, it's ongoing, keeping the parents here, and I think that will make the numbers better. And I know it's slow, but attachment, we all look at the attachment results at toddler age and say, oh, it's 60% securely attached. That's not low compared to full-term infants, but that's not the whole story, I'm afraid, and that's what we have to learn. But keeping the parents with the children, making them strong, all of us are fighting to do that, that will help.
But what I also know is that the attachment of the mother also plays a big deal in the attachment of the baby. That the story of the mother is also a little bit the story of the baby. So I think it's a bigger issue actually than just being born early or being separated. Or, I mean, there are many more angles to this. And even a judgment of bonding. I remember working with Heilisa Als in Boston, that she refused to do the separation, the strange situation test, because she felt it was traumatic for premature infants, and so we had an alternative for that.
Yeah.
But it's very complex, and thank you for this thought-provoking presentation.
So I think we are closing this session. Thank you very much. Yes, I just have one reflection, and I was sitting here thinking, what is stopping us doing skin care more? And I think the problem is us working in the NICU. We love our incubators too much. You can push them up. You can push them down, you can put on light, there are a lot of buttons you can push, temperature up, temperature down, you can open and put your hands in and feel the babies. I think we are the problem, actually. So, now I'm finished. Thank you.
I just have a comment.